So Mark, could you hear the applause?
I could see you clapping. I can hear you a little bit. So thanks, Connie.
So Mariana is here somewhere. Is he able to hear you? Where's Mariana? Okay.
We'll get that fixed. 1 second. Thank you.
Okay.
Okay.
I think we have the capability to take questions from the web and also in the room. You see there are microphones around. Are there any questions you can start lining up while Mariana is working miracles over the auditory channels? Mark, there are a couple of people working their ways to the microphone, so if you can hear me, I think the one question I would say just very quickly, if someone was to say to you, what are 1 or 2 things I can do next week to begin to make a difference on this? Do you have any thoughts about that? And then we have a couple of folks lined up with other questions.
Yeah, you're cutting in and out. I think, Connie, if I heard what you said, what are 1 or 2 things we could do next week? Is that, I mean, I think one thing is, and I think our collaborative's doing this, people don't talk about this. It's still a silent epidemic. So I think one thing we could do next week, and really just raising the awareness is important. I can tell you in our pilot study, we brought a bunch of nurses together as part of that 2-day intervention. Many of them worked together on the same ICU. And what was very interesting is when people started to talk, it was very evident that people didn't realize other nurses that they worked with were having symptoms. They all thought there was something wrong with them, that they couldn't handle the environment, and didn't realize that there was an epidemic going on. And that alone made people feel better and allowed them to better cope with their job. So I think just number one, an easy thing, which is what this initiative is doing in a great way, is just raising awareness so people realize there's not something wrong with them. So I think that's one thing that could be done. And I think the other thing that's been talked about in terms of building a healthy work environment is just improving the lines of communication and make sure that people communicate properly in a effective manner. But this whole concept that's being raised, which I think is very important, of verbal abuse, whether again that's from patients, families, or other healthcare professionals, is not okay. I think that would be something, especially in stressful environments. We all know people get stressed out, they say things they shouldn't say. That's not okay, and that needs to change in an ICU environment.
So we'll start with the microphone to my right.
So I can't hear that, Connie.
Yeah, 1 second. We're getting the microphone working.
How's that? Is that better? Can you hear me? I don't think so. Oh.
Try it. We'll do some translation, but
All right,
not
so
into Portuguese.
I texted the question. I noticed the speaker did not, and if he could please comment on the relationship between PTSD and compassion fatigue.
The question is, do you have any comments on the relationship between PTSD and compassion fatigue?
Yeah, it's a good question. In our theoretical model that the CCSC put together, I think they're all linked. I think if it was a Venn diagram, there's overlap that way. So compassion fatigue or secondary traumatic stress, where people, it's sort of the cost of caring, I think does lead into that. Whether it's a proximal factor or distal factor, I think it depends on the individual. I think it's all part of the same syndrome, which we're calling burnout, and whether we want to be lumpers or splitters, I think depends on what the interventions need to be. So we put it together as a proximal factor that compassion fatigue over time in an ICU setting can lead to temporally post-traumatic stress disorder, but I'm sure it can fit together in other ways. But it's a very important part, and you can see when someone develops compassion fatigue, they're probably not going to want to stay in their job much longer. It leaves that decreased personal accomplishment.
Microphone here.
Hi, and good morning. Are you able to hear me? No.
All right. I'm with you.
Yeah, you're with me. So my name's Peter Angood. I'm the president and CEO for the American Association for Physician Leadership and recovering trauma surgeon and surgical intensivist, and a past president of the Society of Critical Care Medicine. In our data, we have about 4,000 physicians, physician leaders who have taken the psychometric testing, the DISC tool. What comes out of there is a high predominance of characteristics oriented to dominance as well as conscientiousness. And actually create the term of, well, we're a bunch of conscientious dominators. And that's who we are as individuals.
Connie, I can't hear you right now. I'm not sure if I'm supposed to be.
Yeah, we're getting to the question. There's a little bit of lead up, which I'll try and summarize for you.
I'm there.
Question's coming right now. Hang on, Mark.
So
Okay.
with the background of these sets of characteristics that are very prevalent, not just in the physicians, but in the nursing groups as well, is trying to manage
I heard the beginning.
The paradox of we come in with this incredible humanism and altruism, but we have to manage the paradox of the complexity of our environments. So the question being, how do we better manage this paradox of who we are, the conscientious dominators, but this incredibly complex environment with these, in the ICU environment, people dying and incredibly sick. Sorry.
So, Mark, the question relates to a study having been done with 4,000 physicians where using the DISC tool showing that typically physicians have dominant personalities and very conscientious folks who also are human beings. They come into medicine for altruistic reasons and humanitarian reasons, and sometimes that's a disconnect, I guess. So any comments on that balance, I suppose, between those types of characteristics and the role it plays?
Yeah, I think it's as that question alludes to, and I think as we talked about, these symptoms occur in the people that care, and you want your doctors, nurses, and other healthcare professionals to care. It's a major tenet, as I alluded to, of why we went into this profession. So I don't think the right answer is to make people not care. I think that would clearly be not in the best interest of our patients. However, I think you can take people that care, have the right personality makeup, and give them the tools to proper cope with their environment. And as I alluded to with the story about the patient passing away in the ICU, I think the old model was to teach people almost to use not the right coping mechanisms of depersonalization and others to deal with their stressful work environment. So I think as a profession, as healthcare professionals, we need to identify ways to teach people to better cope with their environment, and of course change the environment also. From a critical care perspective, some of the things we deal with, I don't think are modifiable. If you're going to work in an intensive care unit, you're going to be exposed to sometimes horrific events like natural disasters and physical assaults. And I think we need to be given the skills to properly deal with those situations.
Thank you, Mark. We've just been given the 2-minute warning, so we'll take one more question that hopefully I can translate over to you.
Try to be brief. My name is Vonda Vaden-Bates, and statistically on the demographic that was shown earlier, I'm in that one category that had no percentage. I come from the patient family side. My husband died 5 years ago from a preventable hospital error. And so I was sort of struck by the term perceivable, the perceived delivery of inappropriate care. And while I think that that's true, there's definitely a trust issue. It is also true that there's actual and very real harm. And I do think that the only reason I'm here in the room today is because my late husband and I focus very much on sort of the Eastern and Western versions of holistic and whole well-being. And that gives me a little bit of strength to come and just be supportive in the environment of healthcare, because there wasn't a single practitioner that intended to do anything or miss anything. So I think it's important for us to remember the need for transparency about not just the perceptions of harm, which are there for sure, but also the very actual real harm. And I would love some comments from our speaker about that. Thank you.
Can you hear me, Mark?
I can hear you, Connie.
And you could not hear the comments that were just made.
No, sorry.
The person who spoke is a wife of a fellow who died as a result of a medical error fairly recently, and she spoke to the fact that indeed harm is real, errors do get made, and the need for transparency. And my comment to you is thank you for speaking, and some of us were talking just this morning that one of the things we're missing in our work here at NAM so far is the voice of patients and families. But Mark, any comments related to this whole issue of inclusion of patients and families in this work and understanding that perspective?
Yeah, I think it's essential, Connie. I agree with you, and I really do appreciate that the person who asked the question came to this forum. I think the patient involvement, family involvement, especially in the intensive care unit, is essential for a variety of reasons. We need to understand the stresses, and this is becoming a big issue in intensive care unit research. We need to understand not just what patients are dealing with stress-wise in the intensive care unit, but their families. There are very high incidents of post-traumatic stress disorder in family members of patients that survive the ICU because they're working in the same environment. And if we can bring patients, families, and healthcare providers together to properly address this epidemic, because I think there are things that patients and families should want to know about this also. Again, burnout syndrome can lead to medical errors that lead to decreased patient outcomes. I think patients and families want to be aware of that too and figure out collectively how to help fight this epidemic that's there. So I think they obviously need a seat at the table, if not many seats at the table.
Thank you, Mark. I think we are at time, and I also thank you for your comments. One of the things that we have discussed in this collaborative is how do we involve patients and families and message this in a way that is useful but not scary. So we need everyone's voice to help us understand how to do that most effectively. Mark, I really want to thank you, number one, for your flexibility and willingness to play this game over the airwaves. It worked out swimmingly, and I think the group wants to thank you again for your participation.
Thank you very much.